Dear Chairman, in my talk, I would like to present you the results of our analysis assessing longitudinal stent deformation during POT. Here you can see my disclosures. Proximal optimization technique is to achieve proper apposition in the proximal main branch, which can be reached by a certain overexpansion within this segment. It's a common belief that this overexpansion results in foreshortening of the stents. However, data about its exact behavior is scarce. The aim of our study was to describe the exact magnitude of stent longitudinal deformation during overexpansion by POT. We performed first in-bench analysis using 3 and 3.5 mm stent platforms from 5 different vendors. They were implanted in bench models with 3 or 3.5 mm distal reference diameter and a proximal main branch segment large enough not to limit overexpansion. We performed crossover stenting with 10, 15 and 20 mm protrusion in the so-called left main segment to simulate different anatomical settings. And incremental POT was performed with 3.5 up to 5.5 mm to demonstrate a wide range of different POT and overexpansion scenarios. OCT analysis was performed after each step to measure stent length in the proximal, in the distal main branch segment, and total stent length as well. Primary endpoint of our analysis was the OCT-defined stent length as compared to its nominal value. In total, we performed 29 bench cases, and to our greatest surprise, overexpansion, so POT, led to lengthening of the stent instead of shortening. Detailed analysis showed that each step of POT resulted in significant lengthening of the stent length in the proximal main branch segment, shown by the red line, for the 3.0 as well as for the 3.5 stent platform, with no change in the distal main branch stent segment, shown by the blue line, suggesting that this is a real absolute lengthening of the stent, not just a slipping movement or dislodgement within the vessel model. Comparing different stent brands, we haven't seen any difference, neither when we compared 2 versus 3 connector designs. Confirming our findings, the best demonstration I have ever seen with proximal stent lengthening was done during a bench case performed by 2 of the greatest bifurcation operators during EuroPCR this year. I would like to invite you to follow this little clip where yellow line shows the proximal stent edge at the beginning, while red line shows the distal stent edge at the beginning, and operators performed here really a perfect potting, large enough to achieve proper apposition, positioning the balloon nicely to the carina as suggested by the panel, as suggested by the commenters, and by this perfect pot, multiple pots, at the end the case ends with a significant elongation, proximally elongation of a couple of millimeters. With these bench findings, we also wanted to understand whether this is just a bench finding or it has real clinical relevance. It can be observed in human cases as well. So we went back to our OCT databases collecting single stent bifurcation PCI cases, which was done by OCT guidance. We excluded all the cases with stent overlap as well as cases where visualization of the stent length was not good enough for analysis. And we measured final stent length based on the OCT, comparing that to its nominal value. In total, we had 36 cases, mainly in left main or in LAD diagonal bifurcation, with a nominal stent diameter of 3.3. These stents were on average post-dilated or potted with +1 mm. And I would like to show you first a typical case from our cohort. The patient with LAD diagonal bifurcation. Here the wire demonstrates as well as the 2 keys line where the proximal main branch ends. And this 3-0 stent was first post-dilated with 3-5 balloon, and then to correct proximal underexpansion, it was post-dilated with 4-5 millimeter balloon, resulting in marked lengthening within the proximal main branch segment. In the entire cohort, more than 2 millimeter absolute lengthening on average for the cases. How we can interpret it in a clinical perspective? So let's put these findings and try to interpret it within this one single distal left main bifurcation case, where when the stent is placed and has to be corrected proximally with proximal optimization, if the stent is placed nicely to the ostium, then by proximal optimization we might end with such a proximal aortic protrusion demonstrated by the yellow lines coming the data from our cohort. And it's easy to realize that such protrusion might have relevant clinical and procedural consequences. Where does this elongation come from? Our observations suggest that this elongation comes partially from the pot balloon itself. Namely, there is a marked conical tip distal to the distal marker of the balloon, meaning that the proper carinal position of the marker ends with overexpansion within the daughter branch ostium. And in case of a certain resistance here, calcified lesion, strongly fibrotic lesion, results in proximal slipping of the balloon, a kind of melon seed effect, which stretches the stent towards proximal. So summarizing these findings, we believe that indeed POT is still crucially important to correct proximal apposition, but we have to incorporate in our thinking that overexpansion leads to relevant proximal elongation, as shown in bench and also confirmed in clinical cases. This elongation correlates with the magnitude of overexpansion, and therefore elongation has to be considered when stent length is selected, as well as when stent is positioned. And I strongly believe that the ideal balloon type as well as ideal balloon position for POT should be also reconsidered. Thank you very much.